Hi, I'm Jodi Elderton, and this is my DMP Scholarly Project presentation, The Effect of Project JED Education for Depression and Suicide in Mental Health Attitudes and Intention to Seek Help. According to the World Health Organization, depression is the leading cause of disability worldwide and in the United States. It is a silent global pandemic. It's not surprising that the depression rate among college students is 5.2%, given the world statistics. Left untreated, it could lead to suicide, which is the second leading cause of death in students. Think about that for a minute. Depression impairs the students socially, negatively affects academic performance, and can result in self-harm or death. Unfortunately, many students do not seek treatment. Those who seek help may be faced with a lack of services due to staffing, fiscal concerns, and insufficient community resources. When faced with a mental health issue, college students would rather disclose to a peer. Also, a lack of social connectedness in this population is a proven risk factor. Peer-based training will promote interaction and relationships between students, in addition to learning about depression, suicide, and how to obtain help. The JED Foundation has leveraged this concept in its material, You Can Help a Friend. It is a 60 to 90-minute educational program that trains students how to help a peer with suicidal and depressive symptoms. My project examined the impact of You Can Help a Friend on the participants' attitudes and intentions towards mental health seeking behaviors. This study also compared the influence of peer versus faculty-led presenters. The PICO question was, in freshman and sophomore college students, what is the effect of Project JED and peer education for depression and suicide in mental health seeking attitudes and intentions as compared to instructor-led training? IRB approval was obtained before implementing this project. The setting was a Midwestern University's Healthy Life Skills course. The population sample were freshman or sophomore college students who were at least 18 years of age and no older than 50. Participation in the study was voluntary, anonymous, and unrelated to point achievement in the course. Risks to the students were minimal since they could exit the Qualtrics survey at any time. The anticipated benefit was increased knowledge about how to help a peer with suicide and depression. Due to lower enrollment during the summer, the material was delivered in an online asynchronous format instead of a live, in-person classroom setting, which was the original plan. The JED education was pre-recorded in a video format by the same peer or faculty presenter. The presenters utilized the same slides from the Project JED education. Two sections of the Healthy Life Skills course viewed the peer presentation, and one section viewed the faculty presentation. Students were able to access the course content in the time frame designated by their instructor. Recruitment took place in May, while the study was implemented during the summer session. The peer presentations began in June, and the faculty-led presentations were the following month. The original design was to have two sections of each, but the fourth faculty member didn't use the content in the course as planned. So the faculty presentation material was available to those students in that course after the peer presentations had been completed in other course sections. In this qualitative exploratory design, 2 evidence-based instruments were contained within a Qualtrics survey. They are the Mental Health Seeking Attitude Scale, or the MHSAS, and the Mental Health Intention Scale, or the MHSIS. The MHSAS is a 9-item scale that measures favorable versus unfavorable attitudes towards obtaining help from a mental health professional. The MHSIS is a 3-item scale which measures intention towards getting help. These instruments each yielded mean scores. In both instruments, 7 indicates a high mean score and 1 indicates a low score. Students completed the survey before and after viewing the presentation. Each utilized a different Qualtrics link to separate the before GED education and the after GED education. Degree of variability and effect size. There was variability in how some of the students filled out the Qualtrics surveys, the MHSAS and MHSIS. Incomplete survey results were not scored. Cohen's D was used to calculate the effect size, but not utilized in final results because of statistical significance, and we'll cover that later. SPSS was used to perform one-tailed t-test to compare the difference among groups. Descriptive statistics were obtained by calculating the difference in the mean scores pre and post, meaning before and after the GED education for each grouping. There was no demographic information collected during the study. And there were several different groupings that were compared using descriptive and inferential statistics. The combined sample size of both the peer and faculty groups was 51, and then there were 35 total participants in the peer-led groups and 16 participants for the faculty-led group. The last grouping's kind of an outlier. It was comparing the peer and faculty survey results separately calculated between the peer and faculty pre-test and then calculating the peer and faculty post-test differences. For descriptive statistics, both faculty and peer groups combined is designated as all on the bar graph. So that's both peer and faculty combined pre and post GED. And that was N51 was our sample size. And then for the faculty before and after GED and peer before and after GED, and each bar indicates, the dark blue indicates the MHSAS, or that would be the intention, or it would be the attitudes towards seeking help. And then the MHSIS is the light blue, which would translate into the intention to seek help. Overall, the null hypothesis could not be rejected for most of the groups using the inferential statistics. For the faculty-led presentation, there was only one section because one of the 2 course instructors who had agreed to participate did not follow through. So that resulted in 18 students completing the pre-test and only 16 completed the post-test. So this was only one section, one course section. Statistical significance was not achieved for either instruments, either the MHSAS or the MHSIS. For the peer group, there were 2 course sections, and combined it ended up being 34 participants taking the pre-test and 35 completing the survey after the GED education. Mean scores increased for both instruments, but only the MHSAS demonstrated statistical significance at p equals 0.05. Further, statistical significance was also achieved in comparing peer and faculty surveys after the JED education for the MHSAS with P equaling 0.031. And remember that MHSAS is the instrument that measures attitudes towards favorable mental health seeking behaviors. And you can see that on the highlighted one-tail independent t-test for the peer and faculty surveys after JED, highlighted as P equals 0.031. Statistical significance was expected for both the MHSAS and the MHSIS at the beginning of this study. However, it was not obtained in all groupings except the MHSAS in two instances. They are number one, within the peer-led group to recap, and number two, the comparison of peer and faculty surveys before and after the JED education. Consequently, results cannot be generalized to the larger population of college students. So what are the differences? What could they be due to between the observed and expected outcomes? They could be sample size, related to study design, and/or timeline. First, the sample size was small, and this could have contributed to the lack of statistical significance. A larger sample size could have yielded a greater statistical power. In fact, the statistician had calculated a statistical that you would need 101 sample size to get statistical power. So this is a pilot study. And then also a different study design, which paired individual pre and post-test scores, would have been provided results related to the effect of the individual as well as the group. And at the onset of the study, it was recommended not to link those because we were going to have a small sample size and did not want to interfere with the anonymous nature of this. Further, conducting the project in the fall or spring would have provided opportunities for a live in-person experience as opposed to an online asynchronous format. This would have allowed for interaction between students and presenters and facilitated a more impactful experience. Having the study in the fall or spring would also increase the sample size. Also, there may be bias on the part of the researcher in viewing the increase in mean scores before and after the intervention as being caused by the JED education and not other factors. Other factors could include the student's personal characteristics, such as mood or prior knowledge and experiences. Time of day could also influence results, as well as impactful presenters being causative factors for an increase in scores. You know, that the presenters, you know, it wasn't because they were faculty or peer, it was because they were extra persuasive. So those are things to consider that might have contributed to the increase in mean scores. Implications for nursing practice. There are not enough psychiatric providers to meet the needs for mental health care on or off campus. Past evidence has shown that gatekeeper programs such as Project JEDS, You Can Help a Friend, can help bridge this gap since students are more likely to talk to a peer. This would be a first step towards getting students in crisis mental health help and can be life-saving. Future research, there's a lot that can be done. There's a lot that needs to be done. Future research is needed on best practice interventions to improve the attitudes and intentions of college students to seek professional mental health services when faced with a mental health challenge. While the MHSAS and MHSIS are validated to measure attitudes and intentions to seek help, there's a need to measure actual help-seeking behaviors. In other words, the education and the interventions that we're doing with students, how do we measure the behavior of going to the mental health professional, not just the attitudes and intentions, but we want to see what the actual behaviors look like. Also, primary and secondary prevention programs should not only occur in isolated courses. This is a great start, but it needs to be part of a campus-wide initiative to prevent unnecessary loss of life and disability. Remember, depression is a global problem. Students on campus are experiencing depression, and suicide is the second leading cause of death. So let's recap. There was no overall statistical significance. Descriptive statistics demonstrated, though, an increase in mean scores for both the MHSAS and the MHSIS for all groupings after the Project JED education, as compared to the mean scores prior to the education. In comparing the difference in mean scores between the faculty and peer-led JED education, the peer-led groups demonstrated a greater increase than the faculty presentation when comparing the difference before and after. However, like I said before, there was no overall statistical significance for the peer, faculty, or combined groups to reject the null hypothesis. As stated before, several elements greatly influence the outcomes of the project. Low course enrollment, asynchronous online format, and disengagement of one of the course instructors affected results. Statistical significance may have been achieved by an alteration in any or all of these elements. Recruiting more course sections during a fall or spring semester would have provided increased enrollment of students rather than just a summer session, and thus a larger sample size. A live in-person classroom could have facilitated an interactive experience, which could potentially increase the students' MHSAS and MHSIS scores. Finally, the participation of an additional faculty-led group or groups would add strength in comparing faculty and peer-led scores by increasing the number of participants. And I'm looking forward to, after this pilot study, conducting something on a larger scale on my university campus. In conclusion, depression and suicide are prevalent among college students. Peer education programs such as Project JED's You Can Help a Friend can empower students to help their friends and themselves and establish important connections. Thank you so much for your time, and I look forward to your questions and responses. And here are my references.